Good morning. I'm Mr. Nadeem Aslam. I'm an orthopedic consultant surgeon specializing in robotic surgery. We're going to talk today about hip osteoarthritis and hip replacement surgery. The hip joint is a relatively simple joint compared to the knee. It essentially consists of a ball, which is the femoral head. So here we can see we've got a thigh bone and we've got the femoral head on top, and it consists of a socket, which is a part of the pelvis. Right, so we can look at the pelvis. The pelvis is a structure which consists of three bones, essentially the iliac bone, two of those, and then we've got at the back, we've got the sacrum, which is known as the sacrum that is attached by the sacroiliac joints, and at the front, the pelvis is attached by the pubis. So the actual iliac bone consists of the iliac wing, it consists of the pubic rami, and it consists of the ischial tuberosity. And those aspects come together and they form the hip joint. Now, we know that the hip joint consists of an articulation between the bone and the femoral component, which is known as a ball and socket joint. There's a 4mm coating on the socket, a 4mm coating on the head, and as that coating starts to wear down, you're going to get bone on bone, which is going to produce pain. So hip pain can present depending where the damage is. If the damage is at the top of the hip, it's going to cause groin pain. If the damage is on the central part of the bone, it's going to cause pain in the buttock. If the damage is at the back of the hip, it can cause pain deep in the buttock. And there's a percentage of people who are going to get referred pain from the hip going down into the knee. So the pain may go into the side of the hip, the thigh, or it may even be totally in the knee joint. And it's not uncommon that we see people who have knee pain, but the predominant problem is in the hip. So the surgeon has to be careful at treating the right joint. Once that arthritic process starts to get worse, you get exposed bone, which rubs on exposed bone, and the hip will start to stiffen up. So what patients will find is that the movement will start to reduce. So what patients will find is the movement will start to reduce. So they'll get limitations in bend, and more importantly, the rotation will start to limit. And one of the first findings in hip arthritis is that the hip will lose its internal rotation. So it still has external rotation, but it'll lose the ability to internally rotate as the capsule starts to contract. And this means that patients will find it difficult to put shoes and socks on, they'll have difficulty in walking, they'll start to limp, and they'll start to have pain at night. When you start to have the pain at night, that's when the quality of life and the symptoms take on different meaning for patients. So the symptoms of a arthritic hip would be pain which can be in the groin, it can be in the buttock, it can be in the thigh or the knee or a combination. Patients will be limping. They will have noticed a change in the direction of their foot. It tends to turn out. They will not be able to put their shoes and socks on. They'll find it difficult to get out of a chair, into a car, and the walking becomes more and more limited. Eventually, they will have pain both at rest and at night, and walking is very limited. And that's when we'll start to discuss the options of treatment. With all these conditions, there's a conservative plan which would involve pain management initially with simple painkillers, anti-inflammatories, and physiotherapy, which is important as it will strengthen the muscles around the hip. Even if you're having surgery, you would like to have strengthening around the hip, which will improve your recovery rates. Injections in the hip are possible. There is some evidence that they can cause more damage, so we have to be careful. Generally speaking, if we have patients who are unfit for surgery or who are not clear where the pain is coming from, we can inject the hip as a diagnostic and therapeutic step. We can also inject younger patients if they don't want to have surgery. Eventually, patients will reach a stage that we're heading towards surgical treatment, and that operation, in most cases, will be a hip replacement. So in a hip replacement, what we do is we approach the hip and we cut the bone here and remove the femoral head. Now, the approach to the hip varies depending on which surgeon you go to. Some surgeons make a 20, 30 centimeter incision and they dislocate the hip and they release all the structures, and then they'll do the hip replacement and put it all back, which is conventional teaching and is absolutely fine. We ourselves prefer to preserve the muscles and minimize soft tissue damage. So we prefer to do minimally invasive surgery, which is a smaller incision. So we go from here to here. We cut the hip in position, so we're not dislocating the hip totally out. We cut the hip in position and we remove the head with a corkscrew, and that minimizes the stretching and damage to the soft tissues. Then we effectively do the operation, and we keep most of the structures intact and do minimal bone reaming. This is essentially what a hip replacement is. So on the socket side, the surgeon will prepare the bone, ream the bone down, and we'll take a shell which consists of a metal component. We use titanium, and it consists of a plastic liner which is inside the metal shell. This will then be impacted. We use uncemented implants which impact into the bone, and they get a good biological bond. That's the hip side. The femoral side, the bone is hollow inside. So once the head has been cut off, generally speaking, the femur has a canal, and that can be broached. And then the surgeon has the option whether they want to put an implant in which is uncemented, which we prefer biological bond in the younger patients and patients who've got good bone quality, or the surgeon can cement the stem as their preference. This forms the second part of the hip replacement, and then the socket and the ball are then put together. So that forms the hip joint. So in a hip replacement, you no longer have bone-on-bone contact. You have a metal with plastic liner, and then a head. The head can be either metallic or ceramic. It's a preference of the surgeon. We prefer ceramic in patients who are fit, healthy, and younger. I've gone to using slightly larger heads, which give better mechanics and better stability. Now, 90% of people who have a hip replacement will do well. They'll get up, the pain will go, they'll be able to go back to activities. We carry out a minimally invasive approach, which we allow people to walk straight away. There's no dislocation precautions. They can lie on their side. And we let people drive at 2 weeks. And we found that since we've been doing this surgery, the recovery rates have been much quicker. When we carried out conventional surgery, we found a lot of swelling, a lot of bruising, all the way down the leg. Patients have found it much more painful, and the recovery was much more restricted over a 6-week period. We now find that there's minimal swelling, minimal bruising. The patients are walking straight away, and at 2 weeks, the wounds are clean. There's hardly any impairment at that stage, so we mobilize quicker. There are risks with hip replacement surgery. There's a risk of problems such as infection, which is rare. It can be superficial or deep. It may require washout or removal of the components. The hip can be slightly longer or shorter, depending on what the surgeon finds at the time. Hip stability is important, so surgeon may make changes at the time of the operation to make the hip more stable. There can be thrombosis, and in extreme positions, the hip can come out. So any hip, if it's taken to an extreme position of flexion and rotation, will impinge and lever out. So you do have to be careful, although you can do most things. There's also, with any operation, a risk of nerve injury, where you can stretch the nerves and cause weakness in the thigh or the foot. And there's sometimes a risk of fracture if the bone is soft, a hairline fracture of the thigh bone or the socket, the acetabulum. But in most cases, that's very rare, and most patients do well. So this raises the second issue: how do you do the operation? We've always done minimally invasive surgery. We believe that the minimal damage done to the hip is better for patients, because minimal damage means minimal inflammation, which means minimal swelling, which minimizes the inflammatory response and pain. And really, the only what stops patients doing well is pain and swelling. If you can eliminate those, patients will all do well. So we now have robotic technology, which we are leading in this region, which is known as Mako technology. Now, with the robotic technology, we're no longer basing the plan on an X-ray. We're now looking at a CT scan. One of the problems with conventional surgery is the position of the patient is very unpredictable. So when you lie a patient down on the table, you don't really know where the socket is. It could be there, could be there, could be there, could be there. Because all the surgeon is seeing is this small window, which is surrounded by tissues. With the robotic surgery, rather than an X-ray, a CT scan is done. So it gives this image, which we're showing here, which is a three-dimensional image of the pelvis. So the surgeon will know this will be sent to America, it will be sectioned and mapped, and the surgery will be planned on your own anatomy, your bespoke anatomy. So what will come back is what will happen is that they'll be able to work out what the size of your socket is, where to place the socket, and to get the optimal position. And at the time of surgery, we'll be able to monitor where the pelvis is. So this is positioned very accurately. So sometimes the components can look positioned very accurately. For example, here, the socket looks reasonable for what you're looking, but if you turn round, you can see the position is out on that plane. So this is why the technology allows very accurate positioning. The information is fed into a robotic arm, which we control. The operation is not done automatically, and that robotic arm allows us to put the socket exactly where it should. If the surgeon tries to go too deep, higher or lower, the robotic arm will cut out. This means there's no doubt that the studies have shown, and our studies have shown, that the accuracy of the component positioning is improved. And with accurate component positioning, it has advantages in that it reduces the chances of wear, because your joint is not going to an extreme position, wearing centrally. It reduces the risk of dislocation, going into an extreme position and dislocating. And more importantly, we're now minimizing the degree of bone. Now, we have for a long time been carrying out minimal reaming. A lot of surgeons will ream the bone and they'll continue to go deep. We do the minimal reaming. We do a single ream. So we do the minimal reaming just to get the socket in. So this means less bone loss. It means less soft tissue damage, less inflammatory response, and a quicker recovery. We have found patients have had excellent results in recovery, and that's what we're recommending now for patients. Minimally invasive surgery with robotic-assisted technology, which we believe is the gold standard. And we'll talk about artificial intelligence and robotic surgery in a moment. Thank you.